Boys and girls, how's it going? Welcome to week two. We're going to go ahead and start talking about emergency care and shock. Let me open this up. This is really, really short. I'll kind of interject with some more information here, but we are going to be finished with this chapter. And this kind of leads us to an unusual situation. How do we handle taking a test? So I'm going to kind of plan that out. I think tests will be like everything else. We're going to make it a little simpler, but still have some concrete information we got to have put in there. I have the multiple choice test all ready to go. You guys could simply answer. Put your answers in a doc and send them to me. And we could do short answer kind of questions, which would probably be just maybe 3 or 4, 5 questions, maybe that you got a short answer. I'm not looking at doing essay type questions, so that might be for something later if we have to go longer. And that's not even really something I'm thinking about. I'm just kind of thinking out loud. And if you guys have any input, please email me or message me what you think. Ultimately, it is my job to do, but I just want to make sure we all have some input here. So we're talking bleeds, emergency care for shock. Shock or hypoperfusion, as we understand it to be, lack of blood flow through the body. MASH and CPR, metabolic, anaphylactic, septic, hemorrhagic shocks, neurogenic, cardiogenic, psychogenic, or respiratory shock, the different types that are out there, which break into 4: distributive, disruptive. Yeah, I forgot. Okay, 2 more in there. I'll have to remember those. Sorry. Basically, these are the different types of shocks we have to deal with. So how do we treat, how do we care for a person in shock? Let's go back over, the 3 types of bleeds. We have arterial, we have venial, and we have capillary. Capillary is bubbling of blood to the surface of the skin. This is skinning your knee when riding a skateboard. Venial bleeds a deep cut in the skin. It cuts through a vein, dark red oozing blood, right? And then arterial bleed, which is a cut down deep into an artery that actually begins to pulsate, pumping bright red blood out of the body. Obviously, we understand that's the worst case scenario. Venal bleeds can be bad, especially if you're a hemophiliac who don't have the ability to clot. And then you also have multiple venal bleeds could be an issue in itself, but those are pretty well easy to control. And capillary bleeds, keep them clean, cover them up, and they heal on their own for the most part. Let's go back to this one here, the arterial bleed. We should understand that a tourniquet, as you see right here, this tourniquet being used, is a last ditch sort of effort. We actually have the ability to use this. It's much more readily available for us. But reality is, you don't really want to. We have enough help close by that we can get care for this patient as quickly as possible. So we don't want to necessarily put that tourniquet on right away. The first step should be direct pressure, which we see happening right here. Okay, with these hands directly putting pressure over the injury itself, with some bandaging. Remember, most important thing, you have to remember, this bandage here, if it soaks through, begins to drip like it's doing here, you add more on top. Don't take this one off. Leave it in place, okay? Because by leaving it in place, you actually allow it to continue to clot. If this isn't working, the next step would be elevation. Elevation would mean you're lifting the extremity, the injured portion of the body, up above the level of the heart to actually slow the process of bleeding. And then the third step would be indirect pressure, which in this case here, we've got this cut to the forearm. The elbow is probably right about here. So indirect pressure would be about where his fingers are here. Underneath the arm, find that pulsating artery and push that pulsating artery against the bone. Squeeze it hard. You're trying to stop or slow the blood flow to the extremity. To the injury. Same thing for a femoral artery, laceration to the leg, that's an arterial bleed. Locate the femoral artery, which is in the growing area. Okay, you find it and you push that femoral artery up against the femur as strong as you can, and that's going to control that bleed or slow it. If these things don't work, a hand-built tourniquet, which I'm not sure if we did or not. I'm not sure that we did it. I'll find some diagrams to show you how that looks. And maybe I'll give you an opportunity to make some at home. They're really not hard to do. Or the military-grade tourniquet that you see here that wraps around and you constrict. You tighten, twist it, just like faucet, like you're turning off the faucet, stopping the water flow. And then once you get to the point that flow of blood has stopped, then you can go ahead and lock it in place, and we've stopped the bleed, venous bleed, which is a life-threatening thing. So shock, care for shock. We always want to make sure a patient has an adequate airway and adequate breathing, They have a patent, which means working airway, and it's adequate breathing. They're breathing 12 to 20 reps per minute inside that, not shallow, not rapid. It's basically well under control. We control bleeding, which is what we just talked about. Either it's bandaging it, pressure dressing for venous bleeds, or it's direct pressure elevation, indirect pressure, tourniquet, last resort. Control that bleed. Provide oxygen. As you see with air, she has oxygen on her. Again, body's lacking blood flow, and that blood flow is important about providing oxygen, so we need to continue that circulation, and we want to make sure we add as much oxygen in as we possibly can. Position the patient. In this respect, I'm going to talk to you about this. We have two options. Okay, we can actually lay the patient flat, which is the new means to controlling blood, providing shock position, basically, is referred to as a shock position, or prone, because this allows the blood to return back to heart and lungs and brain, vital organs, right? Not in the legs. It actually moves back to where it needs to be. You can't stand up straight for too long being in shock, because eventually you're going to fall down. So we aid the body, first of all, by laying you flat. Now, you can actually lift the legs. Well, excuse me, you can't lift the legs because EMS has told us no longer allowed to do this. I'm going to tell you that I will still do this until somebody from EMS directly tells me I can't, because I've seen it work. By lifting the legs 8 to 12 inches, you move blood out of that lower extremity into the heart, lungs, and brain that much faster, that much quicker. I've watched people come back from complete unconsciousness, lift their legs to what's going on. The eyes are open and they're trying to figure out what's happening. The only reason we can't lift legs is because there is a fracture to the legs, because there is injury to the back, the spine, the neck, because there is chest trauma, because we're going to increase blood flow to that chest trauma, flooding the lungs. CHF, or congestive heart failure, would be another reason we can't lift those legs, and a head injury, because again, we're moving blood back to the head, and in that respect, we're going to cause more pressure, and that's going to be a bad thing in the long run. So there are reasons why we can't do that, but reality is, if none of those reasons exist, it's not a bad idea to give it a shot. Takes us to the last one here. Just talk about the big picture. First things first, in all situations, we want to make sure we have our BSI on standard precautions, right? Initial assessments are going to begin with bleed control, direct pressure, and oxygenation if necessary. In this case, you look at this guy here. We're not really too concerned about airway, right? Because he is up. He is apparently with it. So we're going to start dealing with this bleed as soon as possible. Bleed control plus tourniquet if necessary. In this respect, the tourniquet's going to go right up inside here, because obviously the bleed's right there. His heart is here. Tourniquet here, bleed there, closest to the injury between the heart, right? Bleed control with hemostatic agents. So if it is a cavitational wound, we've got a lot of missing tissue from underneath, we can pack it with this hemostatic gauze to actually get more control over that. Treat patient for shock by laying them flat. That's the rule of thumb now. And secondary assessment, checking pulse, vitals, vital signs, and all that kind of stuff. Secondary assessment, going back over the body, head to toe, and getting those sets of vitals, getting everything packaged up and ready for the transport or for 911 to arrive. All right, guys. So that takes us through Chapter 18. I know this has been really hokey and kind of broken up and strange. I appreciate you guys hanging in there, and we're going to continue to work through this. Once we have an idea, when we all come back, once we get back, we'll figure out how we move on from here. At this point, I'm going to go ahead and continue on with a couple of questions, and I'll probably ask you guys to research some things and stuff like that. I'm again going to try and pop in from time to time doing these types of things specifically because I think there's things that just have to be talked about, and hopefully this is working for you guys. Okay, thanks a lot, and we will talk to you soon.